Good evening, everyone. It's my pleasure to welcome you all to today's panel discussion on rehabilitation management of anemia and pregnancy with chronic rheumatological disorders from physiatrist perspective. The purpose of today's discussion is to explore ideas, share insights, and examine the challenges we face during the course of disease and the treatment. We are fortunate to have with us the distinguished panel of experts who will bring a diverse perspective and rich experience to the table. Allow me to briefly introduce our panelists, Dr. Rezina Banu, Associate Professor, Obs and Gynae, Assistant Professor, Obs and Gynae, Department of Obs and Gynae, Calcutta National Medical College. Dr. Shyamasish, Consultant Rheumatologist, INK Hospital. Dr. Mausumi, Associate Professor, Department of PMR, Calcutta National Medical College. We will begin with opening remarks from each panelist, followed by a guided discussion on key issues, and after that we will open the floor for questions from the audience. My first question is to Dr. Banu. What is the incidence of musculoskeletal pains in your clinical practice?
Musculoskeletal pain is more common in second and third trimester pregnancy, and commonest musculoskeletal problem is leg muscle cramp. It is around 56%, and next to throw back pain. It is also common second and third trimester, that is during the advanced stage of pregnancy. Problem arises more. And among the other problems, there may be pelvic girdle pain, symphysis pelvic pain, more chances of carpal tunnel syndrome, hip girdle pain, pelvic girdle pain. I have already stated before, and it is low back pain is 32 to around 44% linear perspective.
Okay. My next question is to sir. Which are the rheumatological conditions that flare up in pregnancy and which are the remission?
This is an interesting question. Actually, pregnancy is a natural state of immune tolerance for protection of the fetus and prevent its rejection. So, what happens in pregnancy? There is a shift from Th1 lymphocyte to Th2 lymphocytes. That means the lymphocyte population is predominantly Th1, especially in inflammatory conditions like rheumatoid arthritis. But there is a shift to Th2 because Th2 lymphocytes are they have more anti-inflammatory property. So that helps in preventing fetal rejection and protection of the fetus and its growth. So the rheumatological diseases which are mainly Th1 lymphocyte dependent, like rheumatoid arthritis and other inflammatory arthritis, those tend to go to remission because there is shift from Th1 to Th2. So inflammatory arthritis is expected to go in remission, especially in second and third trimester. And the disease which is basically Th1 lymphocyte mediated, that is lupus and other immune complex mediated diseases, those tend to flare because there is more Th2 cell expression. So lupus patients have to be very cautious when they are planning for pregnancy. There is chance that to develop flare during pregnancy.
What are the common MSC complaints in pregnancy?
During pregnancy is associated with a wide range of musculoskeletal problems. It may be due to hormonal changes or due to acquired position of the biomechanical changes. Most common cause musculoskeletal complaint during pregnancy is low back pain. It is usually confined to the low back. It is dull, aching in nature, and sometimes it is referred to thigh or buttock. This pain is followed by pelvic girdle pain, which is pain in the pelvic region. It is a sharp pain, often associated with radiation to perineum, to groin, or to hip. Some patients present with sciatica-like syndrome. Other complaints are hip pain, pain in the ankle and foot. There may be leg cramps, particularly at night or during the rest, or some patients present with neuropathic type of pain. It is like present with the tingling sensation and the wrist and at hand, pain with tingling sensation at the hand. They present with the carpal tunnel syndrome or sometimes tarsal tunnel syndrome in the foot. The least common cause of pain, musculoskeletal pain in pregnancy is neck pain, upper back pain, or shoulder pain.
What are the rheumatological conditions would be associated with recurrent pregnancy loss?
The two important causes that are associated with recurrent pregnancy loss are first commonest cause is antiphospholipid symptoms. Next is pacing.
Which analgesics can be used in pregnancy?
Analgesic, most commonest and safe analgesic used in pregnancy is acetaminophen, that is paracetamol. It can be given in all trimester. And next is other NSAID. And these are also can be given in first and second trimester, but they are used to be restricted in after 30 to 32 weeks of pregnancy because if it is given after that, there is more chances of patent ductus arteriosus in fetus.
Next question is, sir, preconception counseling for patients with rheumatoid disorder.
It's very crucial part of treating any rheumatological patient, female patient. First thing is pregnancy needs to be planned. It is unexpected pregnancy or accidental pregnancy is not at all desired. So first thing first. So pregnancy has to be planned. It has to plan pregnancy. Secondly, when to take the pregnancy. Thing is that disease has to be under control. Be it lupus, be it rheumatoid arthritis, has to be under control. Otherwise, there will be, the pregnancy will not be smooth. Thirdly, there are some pharmacological considerations. That is drugs. Some drugs needs to be stopped during pregnancy, and some drugs might need monitoring during pregnancy. So, mainly these three things we have to discuss with the patients and patients' relatives, especially husband of the patient. So that way we can proceed to a successful pregnancy.
With that continuation, sir, which DMARDs are contraindicated and which are safest in pregnancy?
Yeah, actually, this can be a topic of a large bigger discussion.
Yes,
Among the DMARDs, some are non-biological conventional DMARDs, some are immunosuppressives, and others are biological DMARDs. So we can categorize into three. One is conventional non-biological DMARD, which includes methotrexate, sulfasalazine, hydroxychloroquine, leflunomide. Most commonly used drugs in rheumatoid arthritis, especially. So among these things, methotrexate and leflunomide should be avoided during pregnancy. Actually, this methotrexate and leflunomide should be stopped pre-conception. Whenever patient is planning for pregnancy, these two drugs needs to be stopped. And I am not going to elaborate. Other two like sulfasalazine and hydroxychloroquine, those are safe during pregnancy, also in lactation. So those two medicines can be continued. One thing I need to mention that both methotrexate and leflunomide, because these two have teratogenic effect. Methotrexate should be stopped at least 3 months prior to planned pregnancy. And leflunomide has to be stopped at least 1 month prior to planned pregnancy. But for patients who was female patient, patient who was on leflunomide needs to be treated with cholestyramine. Okay, so That's needed. And regarding the immunosuppressives, commonly used immunosuppressives are cyclophosphamide and microbate. Both of these immunosuppressives cannot be used during pregnancy. Those should be stopped before planned pregnancy. And azathioprine is another immunosuppressive which can be used. It is safe during pregnancy and also during lactation. Calcineurin inhibitors like cyclosporine and tacrolimus both are safe during pregnancy. So these are the things we need. We may need during pregnancy. If patient is going. If a lupus patient is planning for pregnancy during pregnancy, azathioprine, cyclosporine and tacrolimus. These things can be used. Those are potent immunosuppressives. Those can be used. And regarding biologicals, TNF inhibitors, all TNF inhibitors, including adalimumab, infliximab, golimumab, certolizumab, and etanercept, all the TNF inhibitors can be used during pregnancy. Only one thing we need to keep in mind that if a patient received TNF inhibitor during the third trimester, the baby should not get any live vaccine within first 6 months of its life. Okay. And regarding the other biologics like rituximab, which is B-cell inhibitor, like tocilizumab, IL-6 inhibitors, anakinra 1 inhibitors, these things should be avoided during pregnancy mostly because lack of data.
Next question is to Mausumi ma'am. Which physical therapies are safe in pregnancy?
Physical therapy should be chosen very carefully during pregnancy to ensure the safety of the mother as well as the baby. Regarding the physical modalities, we can use the superficial heat or cold therapy like cold pack, hot water, contrast bath, or we can also use the aqua therapy or pool therapy. And other pains may be other modalities. Pains may be used during labor to decrease the pain associated with labor, but its safety during pregnancy is not yet been recognized.
Ma'am, can you explain the role of prenatal exercise programs?
Prenatal exercise is very vital because during pregnancy there are some changes occur. It may be due to hormonal changes, or it may be due to biomechanical changes, or overstretching of the abdomen. So abdominal muscles become lax. There shifting of the displacement of the center of gravity. So there is overall biomechanical displacement. There is overstretching of the pelvic floor muscles. So weakness of these muscles. So if we do the pelvic prenatal exercise, it decreases the sum of the associated problems like low back pain, pelvic pain, hip pain, or it maybe it decreases some of the complications that may arise during pregnancy, like gestational diabetes, overweight during pregnancy, or preeclampsia. It helps to control the weight of the patient and well-being, and also it helps that during the exercise, pelvic floor exercise, it helps to ease the patient child labor. It helps to smooth parturition. It helps.
Next question is to sir. Management of SLE flare-up in pregnancy.
All flare of SLE should be treated with steroids, and steroid is safe. Even methylprednisolone pulse is also safe during pregnancy. So that can be safely used. Second thing, among the other immunos, even another safer option is if someone wants to avoid giving pulse methylprednisolone, IVIG. IVIG is very good and may replace IV methyl prednisolone. So IVIG is safe in pregnancy. IVIG can be used to treat lupus during pregnancy. And regarding the high dose steroids, we give during the early stage of flare, at the beginning of the treatment of flare. So we have to continue something, some other immunosuppressives. As we have already discussed, the mycophenolate cannot be used during pregnancy because of steroid and also cyclophosphamide. But there are other drugs like azathioprine can be used, and tacrolimus can be used. So these things may be used, but it has been said that if it is really required, cyclophosphamide also can be used. Knowing that it has the teratogenic effect, because our primary, the goal of treatment for of lupus during pregnancy flare, if it is life-threatening or organ-threatening, to save the mother. Okay, so in those extreme situations, we can use cyclophosphamide and also rituximab, though it is usually not recommended. But in those desperate situations, we may use cyclophosphamide.
Sir, tell us something or clinical features of neonatal lupus.
Yeah, what is neonatal lupus? Neonatal is a very interesting immunological disease. This occurs because of passive transfer antibody to the fetus. So if the mother is carrying anti-Rho, that is anti-SSA or anti-La or anti-SSB antibodies, those antibodies will pass to fetus. And ultimately, the baby will be carrying that antibody, either of these two antibodies. And those two antibodies will be responsible to develop neonatal lupus. So what are the features of rash? There are mainly three organ involvement in neonatal lupus. One is rash, skin involvement, liver involvement, cardiac. Okay. So skin involvement is very typical. There is circumscribed lesions. Sometimes raccoon eye can be seen, but in all patients we do not see raccoon eye. But lesions are circumscribed lesions with central carrying and peripheral elevation, reddish lesions. So multiple lesions, mostly in the scalp and face, and also in the body, on the body. This is about skin. Liver enzyme elevation may be seen in neonatal lupus. And third is the most rated complication is complete heart attack. The problem is that these two, liver enzyme elevation and cytopenia, they often develop cytopenia, pancytopenia or maybe leukopenia only. So this leukopenia, cytopenia, liver enzyme, liver abnormalities and skin abnormalities, those go off. These antibodies may persist up to 6 months in the body of the neonate, and so after 6 months, the expected symptoms will be gone. But thing is that this congenital heart, once it develops, it will persist lifelong and may require pacemaker in many of the patients.
Next question to Rezina ma'am. Precautions taken during delivery of a SLE patient.
SLE patients frequently suffer from renal disease, like lupus nephritis, and these patients are high risk for abortion, and during the miscarriage, IUD and IUGL. So in this patient, care to be taken regarding the baby and mother. During surveillance of baby, frequent monitoring of the baby's heart rate and ultrasonography and fetal surveillance required by doing ultrasonography and Doppler studies to detect IUGR, and as the SLE often associated with Alpha syndrome, and these patients receive low dose aspirin and heparin to prevent thrombosis. With this, they also frequently for bearing up, they receive glucocorticoid, and so you all know glucocorticoid causes thrombocytopenia, and this coagulation before delivery to be checked. And to be keep in mind that there may be during the delivery cesarean section and the vaginal or cesarean section classes of bleeding will be precautions will be taken according to the case of time. And urine analysis will be done to know the kidney status, detect Anaemia, and there is more chances of preeclampsia, eclampsia, so BP monitoring, and hypertensive crisis to be managed according to the conditions of the patient. And during labor, usually regarding the anesthesia as part of the and pain relief during labor, usually continuous the epidural anesthesia is preferred instead of spinal anesthesia, because patient might have altered bleeding while coagulation profile, and in this cesarean section to get delivery because of to prevent or during hemostasis to be maintained properly. And hypertension part already I have explained. And during delivery, before cesarean section, as if this patient usually if patient received corticosteroid for 3 weeks during the last 6 months, suppression of adrenal axis adrenal cortex may happen. So that's why corticosteroid to be given before the cesarean section or delivery.
Rehabilitation of SLE patient in pregnancy. Rehabilitation of SLE in pregnancy, it should be multidisciplinary. As in other rehabilitation program, rehabilitation is always multidisciplinary. It includes the obstetrician, rheumatologist, and also the physiatrist with allied health professionals. It focuses on the antenatal care and planning, prenatal care and planning, antenatal follow-up monitoring, and also the postpartum follow-up. Antenatal care is most challenging part. Already Dr. Shyamasish has told that planning for pregnancy is very important, because planning should be done in remission phase, at least for 6 months or 3 months. The medicine which are harmful to the fetus already discontinue. We have to discontinue the medicines that are harmful to the fetus and monitor the health of the mother, like hypertension, proteinuria, and any other condition, and the antenatal counseling of the patient, whether about the high risk pregnancy of SLE, the symptoms, and whether it is a flare up symptoms. He must know the flare up symptoms of SLE and the risk and consequences of the pregnancy. She must know. During the antenatal period, regular follow-up to monitor the health checkup of the mother, proteinuria and hypertension, as well as is there any growth retardation of the baby is important. And in this phase, fatigue is a big problem. So physiatrists take care of the pain, fatigue, other musculoskeletal symptoms. Here the occupational therapist, it is the role of occupational therapist to educate these patients about the energy conservation technique, about the joint protection technique, and that some exercise therapy which are low impact exercises, like low impact aerobic exercise is advised, like walking, aquatic therapy, gentle range of motion, stretching exercise. These are prescribed to the patient. During the postpartum period, this rehabilitation should continue up to the postpartum period also, and there is a chance of flare, so we look for the chance the symptoms of flare, and also the continue the physiotherapy, occupational therapy, and the exercises should be continued. And this
Ma'am, my next question is to Rezina ma'am. Maternal and fetal complications of APS in pregnancy.
Fetal complication, first coming to fetal complication, APS usually detected by the complications, obstetrical complications. Mother is coming with recurrent pregnancy loss, commonest symptom, and they also have a history of thrombosis, may have history of arterial venous or arteriovenous thrombosis, and recurrent pregnancy loss is the commonest complication in fetus. There may be preterm labor, IUGR, or preterm labor is mainly due to preeclampsia and all, and mother also having thrombosis problem and hypertension, more chances of hypertension and placental insufficiency and IUGR. And IUFT also.
Okay. What contraceptive is preferred in APS?
Antiphospholipid syndrome, estrogen is to be avoided, as there is more chances of chances of thrombosis in APS. So as estrogen is thrombogenetic, it causes thrombogenesis, so estrogen is totally avoided. Progesterone only pill, and progesterone is safe during puerperium to use as a contraceptive. Like we can use progesterone implant. And now in our government setup, we have launched a program by using single rod progesterone, and we insert in the inner side of the forearm, forearm.
Okay.
And progesterone only pill can be given orally, or DMPA injection can be given, or she can use copper T IUD, intrauterine contraceptive device, IUCD device, or barrier contraception, permanent sterilization can be used also.
My next question is to sir. Difference between primary and secondary APS.
Primary antiphospholipid syndrome is a condition when there is no underlying other connective tissue disease like lupus or HCT or any other connective tissue disease. And secondary APS when there is associated SLE or other connective tissue diseases. And so this is the main differential.
Okay, sir. My next question is from Mausumi ma'am. Role of occupational therapy and assistive devices in rheumatological conditions in pregnancy.
Occupational therapy basically they help in activities of the daily living. So they use the psychological and physical and well-being of the patient. They help some exercises are done under their supervision of the occupational therapist to increase the joint range of motion, and they teach the patient to joint protection, energy conservation technique, and the modification of the work by breaking the work into small part to decrease the energy conservation and to decrease the joint to increase the joint protection. And also some they use some assistive devices to help the patient, and to also some home modification like use of grab bar, use of some utensils which are broad way utensils to make to do the household work easier. And
Next question is to sir. Obstetric complication of systemic sclerosis.
There is no specific complications like many other chronic diseases. The complications might be IUGR, preterm labor, and in fetus especially, and in mother. I think before conception we have to some conditions we must exclude, like PAH, pulmonary arterial hypertension, should not be there. In systemic sclerosis, pulmonary arterial hypertension, ILD, these are the two main major organ disease or condition is associated. So EH should not be there, and severe ILD with respiratory failure, symptomatic ILD. Those patients should, or there is heart failure. Those patients should not plan for pregnancy. Pregnancy is content indicated in those cases. If those things have been excluded, then patient might plan for pregnancy. And preeclampsia also complication in mother.
Next question is Rezina ma'am. What are the teratogenic effects of mitochondrial midfield?
Urofacial abnormality. It is OTPCN drug, first of all, when given in first trimester, and causes urofacial abnormality, midfacial abnormality, micrognathia. I think.
Next question is to Mausumi ma'am. Causes and management of pregnancy-related pelvic girdle pain.
Pelvic girdle pain is very common. It is due to during pregnancy there is a hormone is released, that is relaxin, which causes decrease the tensile strength of the ligaments and also the bony joints. So there is a laxity of the ligament and joints. There is also due to please repeat the question.
Causes and management of
Pelvic girdle pain. There is also the pelvic floor muscle, which is overstretched during pregnancy. It decreases, it goes down at approximately 2.5 centimeter during pregnancy. So there is a laxity. Also there is displacement of the center of gravity. So biomechanical derangement is there. So this is the pelvic girdle pain. Usually occurs in the pelvic region. Near the posterior iliac spine, gluteal fold, and also the bony pelvis around the in front of the symphysis pubis. So during pregnancy we use this almost conservative treatment is done, and this is done by superficial heat, superficial modalities, exercise like Kegel's pelvic floor exercise, pelvic floor strengthening exercise, which is Kegel's exercise, and also some support of the pelvis is also, and positioning is very important. Positioning, do not lie on the supine position for prolonged period. Positioning is also very important.
Next question is to you. Diastasis recti is common in pregnancy. What is the rehab protocol?
Diastasis recti is the separation of the rectus abdominis in the midline. So it is common in pregnancy, but it is also occurs in without pregnancy. It also occurs during pregnancy. It occurs due to overstretching of the rectus abdominal muscles, which is when it is beyond the elastic capacity of the rectus abdominis muscle. Then there is separation of the rectus abdominis and diastasis rectus. Almost it is during pregnancy, it is management is done, conservative treatment is done, and it takes a long time, almost 6 to 18 months to recover. During pregnancy we have to as there is a laxity of the abdominal muscles, we have to do the core muscle strengthening exercise, particularly the transversus abdominis muscle strengthening exercise, and also the pelvic floor muscle exercise also done, and some band or support can be, abdominal support can be given to decrease the pain and discomfort.
My next question is to Rezina ma'am. Maternal and fetal complication of anemia.
Anemia is the most common, iron deficiency anemia in our country is most commonest cause of anemia in our developing countries, and anemia is a major health issue, and it causes most common cause of anemia is, as I have told, is iron deficiency anemia. So this patient usually suffer from weakness, anorexia, lassitude, and other problems. And there is more chances of heart failure if mother is having severe degree of anemia, and she might have heart failure at 30 to 32 weeks of pregnancy, during labor, or immediately after the delivery. And most commonest threat and most dreaded complication is postpartum hemorrhage, and it is also the almost second most or commonest cause of maternal morbidity and mortality in our country.
Yes.
So anemia is the most important cause regarding maternal death and maternal morbidity. And during puerperium, she might have sepsis, more chances of sepsis, lactational failure, some involution,
Yes.
and all. And regarding the baby, as we all know, baby takes its iron from mother as long as mother is severely till she is having storage iron. But when storage iron is almost depleted and with severe anemia, baby may be a low birth weight, and there is more chances of stillbirth and fetal death due to hypoxia to the mother and fetal distress.
Ma'am, please explain the contraindication of oral iron therapy.
Oral, first, in a pregnant woman with iron deficiency anemia, we give oral iron, first modality of treatment. And usually by taking oral iron and proper monitoring of the hemoglobin status during pregnancy, we can manage the pregnancy if we see the patient from the very beginning of the conception. But when woman comes in later stage of pregnancy, during that period it becomes difficult to manage with severe anemia with iron and all, iron therapy. And iron contraindicated if she is non-compliant to the medicine, or she cannot tolerate the drug. She is having severe vomiting and constipation that cannot be, and she is non-compliant and she cannot tolerate, or she is having severe gastric, peptic ulcer disease, or inflammatory bowel disease. As we all know, iron is absorbed from duodenum. So any problem or bowel disease, it is or hypersensitivity to the drug, in that condition iron is oral iron is contraindicated.
Ma'am, what are the indications of parenteral iron therapy in pregnancy?
Non-compliant patient to oral iron, patient is intolerant to oral iron, or patient is made in last trimester of pregnancy when less time is available to increase the iron by giving oral iron. We all know oral iron takes time to increase the hemoglobin. So in that case, either we can give in the mid trimester, or last 2 weeks we can give IV iron, like iron sucrose and iron ferric carboxymaltose. And near the term, almost within 1 month of delivery, near date, we can give blood transfusion to correct the anemia.
Oh. My next question is to Mausumi ma'am. Ma'am, role of posture training in pregnancy.
Role of posture care. Actually, due to already I have discussed that there is a bad posture due to increased size of the uterus, gradual increased size of the uterus, or there is a joint instability. The posture patient is a very bad posture sometimes, and this posture causes low back pain and other pain. It increases the pain and associated non-specific pain of the back pain, neck pain, hip pain. So we have to take care of the posture so that the patient can if we take care of the posture, some of the symptoms of pregnancy related pain and symptoms, these are decreased during pregnancy.
Okay. My
Patient should not be in supine position for prolonged period after first trimester. During getting up from the bed, should roll to side and then with the help of the hand get up, not with the pressure over the abdomen, and should stand with do not stand prolonged period for in the same position, and he has to educate the position during sitting, during standing, and during weight lifting. All these we will have to teach.
The final question is to sir. Role of heparin in APS in pregnancy.
Yeah. So we can consider two kinds of patients who are planning for pregnancy with patients suffering from APS. One is thrombotic APS who has previous history of arterial venous thrombosis or microvascular thrombosis. The other one is only obstetric APS, no history of venous, arterial or micro circulation thrombosis. First we will consider obstetric APS, the patient who has recurrent fetal loss but no history of thrombosis. So those patients, once confirmed pregnancy, once pregnancy is confirmed, immediately heparin should be started. And not only that, in the pre-conception period, patient should be started with aspirin and folic acid. So aspirin and folic acid will be continued, and once pregnancy is confirmed, heparin should be started. Nowadays we use low molecular heparin because of the convenience of use. So conventional heparin also can be used. So heparin should be used in prophylactic doses, not in therapeutic doses in those patients. And there is another group of patients who has thrombotic APS and planning for pregnancy. So those patients are already on warfarin or other. Usually we use vitamin K inhibitors, not the newer oral anticoagulants. Those are not good in APS. So this patient on acetram or warfarin, these patients conceived, and once pregnancy is confirmed, will start with enoxaparin, heparin, and also aspirin. So during pregnancy, patients should get aspirin as well as heparin, both.
Okay.
But in these patients, heparin dose should be more, because in thrombotic APS patients, dose of heparin should be more, okay, in therapeutic dosage.
Sir, any question from chairpersons?
I'm asking one question. Dr. Shyamasish does. One 2 years old baby suffering from rheumatoid arthritis. She has taken a long time Moserator, and HSCT scan of the chest reveals interstitial lung disease, C1 pregnancy. Please tell what DMLD or biology C1 to get, what C0.
So long-standing RA with ILD. So once you get pregnant, whether you should, or medicine should be continued. First thing is ILD should not be very severe, as I mentioned previously, that, and also there should not be any associated pulmonary arterial hypertension. So those things are extremely mild ILD. Those patients, that patient can undergo pregnancy and tolerate pregnancy. In those cases, as we have mentioned, that methotrexate cannot be given. Methotrexate is not effective in ILD, but is effective in joints, in rheumatoid arthritis. So methotrexate cannot be given. If there is a chance of flare, or if we anticipate a chance of flare, we can treat the patient with steroids, low dose steroids, and salvasalazine and hydroxychloroquine can easily be used. Thing is that what to do for ILD? How shall we continue treating ILD? Mycophenolate mofetil or rituximab that we commonly use in ILD, those cannot be used. So azathioprine can be used. Thing is that how symptomatic is the ILD? I think if ILD is very much symptomatic, the patient should not undergo pregnancy. So this is the thing. I think we should plan very judiciously that which patient, this patient should undergo pregnancy or not. If symptomatic ILD, severe ILD, we should discourage the patient, because there is chance of complication to the mother. and we'll try to treat the patient with conventional DMARDs only rather than aggressive immunosuppression.
Hydroxychloroquine?
Hydroxychloroquine, sulfasalazine can easily be given. Also low dose steroid.
Thank you very much to all our panelists for sharing the valuable insights and to the audience for your thoughtful.
Now I want to highlight one more thing, that is what are the different indicators. We usually have patients like rheumatoid arthritis in very common way. What are the basic indicators that we should know the levels so that we can use the drugs that we have discussed initially?
I didn't understand the question actually.
What are the basic blood indicators for the rheumatoid arthritis that should be checked during pregnancy to monitor the disease activity?
Yeah, mostly inflammatory markers like ESR, CRP, those actually indicate whether patient is in flare or not.
What is the level of the CRP? Basically what?
Oh, if it is high, if it is more than 6 mg per liter, so that is the cutoff usually that we use in our conditions. So if it is more than that, then we have to consider, obviously excluding other infective conditions. So
It is only dependent on the symptoms. If the patient has no symptom, that should be to this test or?
no, definitely not. If patient complains of pain, usually RA patients goes in remission in pregnancy, but it is not the rule. Some patient may develop flare during pregnancy because we try to decrease the dose. We stop some medicines, say methotrexate we have stopped, and we have continued other medicines. So patients are aggressive rheumatoid. So some patients will flare during pregnancy. So if there is a symptom of flare like joint pain, early morning stress, joint swelling, those kind of things, then we can check with the ESR, CRP. And usually what we do in those patients who develop flare in pregnancy, we can use TNF inhibitor and adalimumab and because we can avoid steroid also. So that is another.
So this is actually a multidisciplinary approach.
Definitely.
We should have a common protocol. It is very much need of the hour right now. So it's a very wonderful discussion that we are having the is announced the new one. So this is the very, we should have go for the next thing we can do that we should have a protocol so that we can
Absolutely.
have some protocol for this patient. Because these are the time when we have a Indian Orthopedic Association. We have in Indian in Indian Orthopedic Association, we have a special emphasis on elderly people because these are the things which affects the people later on. In the age of 32, you would not have many problems because this is only the case of the remission or the flare up. This we should know. But in long run, when the patient is become aged, this will affect his activities and mobility. So we are very much careful about this rheumatoid disease so that it should be controlled properly because the patients have come to the different people. It may come to the gynecologist, it may come to always come to the PMR and also rheumatologist is the main person, key person who are very much. No, I am orthopedic surgeon. So this is a very big problem for us because we got the deformity. And in the age of 55 years, when we got the patient is having some varus deformity on the knee, what is the option? We have many options right now. So this type should be, we should focus on this arthritis part because later on this will affect in long run because right now our life expectancy in Kerala is 80 years for the male. So this is the scenario of India right now. After 10 years, it may also increase. So we are very much careful after 40 in case of female.
Patient with pain, mostly. In the life, live long.
No, they have some degenerative.
Sure.
So this we should know how to make our joint fit for the next prevention of the deformity. So it is very interesting for me also.
It's iron deficiency anemia by measuring this ferritin level. But with this common rheumatic disorder or chronic inflammatory problems, ferritin level as such is high. So monitoring in those patients of iron deficiency anemia with ferritin is rather is not very much actually practical. So this has to be well active. But in those conditions, iron with oral iron also patients not usually respond very well. In those cases, maybe parenteral iron or shifting to lactoferrin often helps.
I am Arun from New Product Manager from Apex Laboratory. Usually during the pregnancy, the B complex absorption is very less actually for the patient who taking the methotrexate. So in that conditions, how we can manage that B complex supplement and also the methotrexate for the pregnant woman who having that rheumatoid arthritis. So during that pregnancy, B complex is an essential supplement. But during pregnancy, patient who having that rheumatoid arthritis problem, primarily they used to take that methotrexate. Methotrexate usually block the B complex absorption. So in that conditions, how we can manage that methotrexate along with the B complex supplement for the pregnancy who having that rheumatoid arthritis.
Usually, the complex is not detected with methotrexate. As
I think in pregnancy, methotrexate should not be used.
methotrexate is it is contraindicated, absolutely contraindicated during pregnancy. So she should stop that methotrexate before conceiving, before embarking on pregnancy.
Some preparation, all preparations are having this. So methotrexate, as she is saying, most of the preparation of folic acid containing vitamin B complex pyridoxal phosphate. This is not active form of folic acid. So this is more or less a routine practice for all obstetricians. There is no problem. But what you are saying is very, very important, because normally if we do not have an interdisciplinary, this togetherness is a big problem, because if we catch something, say rheumatology, and if we see somebody is having a rheumatological problems with pregnancy, we should immediately refer it to a good rheumatologist to take care of this instead of gynecologist or obstetrician controlling that problem. That is a basic something you should treat immediately and refer it to a particular specialist instead of we ourselves doing everything. So that is a big problem. And regarding all heparin and all those, probably also those people should be also put into this combination, so that everybody should be involved. This is a multidisciplinary approach that should be there so that we can reduce the problem. And as far as the bone compensation they are saying, because the premenopause, if we give a lot of calcium and all those, probably we can reduce these problems of bone osteoporosis and all those. As you are saying, osteopenia and osteoporosis. So that should be a routine practice for obstetrician and gynecologist. But once ever there is a problem, we should not treat everything by ourselves. So there must be a multidisciplinary approach so that the patient will get the maximum benefit.
But one thing, just obstetrician, leave it to the hematologist, not that. It's together. They should manage the patient. Don't leave it to the hematologist only and shake off your responsibility.
That is together.
It is too much. They should treat and manage it together. Discuss it and together you have to manage. Okay? Thank you.
Thanks to all the panelists, the moderator, the judges, and the audience for joining us for this interesting academic discussion. And with that, can Dr. P.S. Chopra please sum up? I think he already has summed up the proceedings, but if you can sum up.
We are having some questions in our group, and the questions designated to the person is not at all interested. The other questions are very much interesting for the people. My wife, who is while he was reading, he was very much interested what is the other questions, because this is the time when we have no idea about this what is called this biological treatment. So this now we have some idea. And this should be advised, as ma'am correctly pointed out, that we should know also, before we should also know the knowledge of the rheumatologists. Definitely they have the better knowledge than us. But we should also know the thing that is what to be continued and what to be discontinued. So these basic things, this type of CME is very much useful for us because we are the orthopedician. We have nothing to do with this right now because when this deformity comes, so at that time we are very much activated. But before, to prevent this deformity, this type of discussion is very much important because when we dealing with the patient, this is not that everything is known by us, but the basic thing, that is the rheumatological drugs, which drugs should be given, which drugs should be contraindicated, this should be a clear-cut knowledge. So this is a very useful and very good CME. I always encourage this type of CME, and we have a group, and we should remain as a group for our patient who have come with the best thought that we are the very good for their health. Thank you.